Importance of directed revascularization, and I'm going to talk now about some endovascular techniques to potentially achieve that. My disclosures are the same as from the last talk. So when should you consider a retrograde pedal or tibial access endovascular approach? In our practice, we usually limit this to the treatment of limb-threatening ischemia. It's most beneficial in patients who have complex popliteal or trifurcation occlusions that may be difficult to cross from an antegrade approach. Usually we try the antegrade approach first, and it's in those patients where we fail with an antegrade approach when we consider the retrograde direct pedal or tibial access, and usually also in patients who have limited bypass options, so it's important to accomplish an endovascular revascularization. Here's an earlier case that I did early on in my experience. This was a diabetic patient with a common diabetic pattern here with diffuse tibial occlusions. Here he's got an occlusion of the distal tibial popliteal artery, tibial perineal trunk, and essentially occlusion of all of his main tibial perineal vessels. But we got the hint here that there may be a dorsalis pedis target on the foot. He had failed several antegrade attempts at revascularization, and we approached him after failing an antegrade approach with a direct access to the dorsalis pedis artery that you can see here. In this particular patient, as common in many diabetics, the targets were quite calcified, so that actually helps with seeing your target so you can gain needle access to the target. We use a micropuncture needle and access kit. And here you can see that a 0.014 inch guide wire was able to be advanced retrograde up the anterior tibial artery. This is doing a little bit of an angiogram via this retrograde access, just using the inner sheath from that micropuncture set so that we didn't place a large catheter or sheath into this dorsalis pedis artery. We were able to then cross the occlusion in a retrograde manner from the dorsalis pedis artery access. Here you can see we used a 0.014 inch quick cross catheter, support catheter. This is using a sheathless technique, so there was no sheath involved here. And then ultimately from our antegrade approach, we were able to snare that wire from above and achieve through wire access and then complete the remainder of the interventions from an antegrade approach. Here you can see once we've basically now got wire access from the femoral approach, we've given up our dorsalis pedis access. This is just my finger applying a little pressure to get hemostasis, and then did angioplasty to complete the revascularization, successfully revascularizing the dorsalis pedis artery in this particular patient and allowing him to heal his foot wounds following the toe amputation and achieve limb salvage. This is the typical setup where you usually have antegrade, common femoral artery access, and then access retrograde through a pedal or tibial artery approach as well. So the way that I usually achieve access, there are a variety of different ways to image your target and to gain access. The most common one that I use is actually angio or road mapping guidance, where we're doing some contrast injections via a femoral sheath in the ipsilateral limb. You can then align your needle with the target vessel in one view and then use a 90-degree perpendicular view as you're introducing the needle to view the needle depth in relationship to the target. And calcified vessels actually can sometimes be helpful because you have that calcification that you can see as a target. Do also use ultrasound guidance, but that can be actually a little bit more challenging. I think the angiographic road mapping technique is a little bit easier. And then a lot of times to prevent vasospasm in these small pedal and tibial targets, we'll include nitroglycerin in our local anesthetic that we're injecting around the vessel to combat spasm. So here you can see in this particular case now in the perpendicular view, we see that our needle went in, we're able to advance our guide wire. There are a variety of different retrograde approaches that can be utilized with different target vessels and with different materials. In some ways, this is related to the angiosome or the area that you're trying to revascularize. It's very easy to access the dorsalis pedis or distal anterior tibial artery and the posterior tibial artery at the ankle level. Also in the lower leg, you can directly access the perineal artery through the interosseous membrane using an approach from the anterior side. In the proximal leg, if you're trying to deal with a popliteal artery occlusion, actually the proximal anterior tibial artery turns out to be a very good target and probably is the most useful target in the upper leg. Usually use 0.014 inch guide wires. I like the Cook wires, the Hydro ST, and the Approach CTO wires I use a lot. Sometimes for a little bit more support, I use like a V18 wire from Boston Scientific. We use support catheters, particularly when we're using a sheathless approach with the 014 Quick Cross, and I also do like the 018 CXI catheter, and that one's non-tapered, so you can put it through some low-profile sheaths. You can actually introduce low-profile balloons through a direct retrograde access. You want them to be less than 2.9 or 3 French. I found some of the coronary balloons, like I've used the Maverick balloon, and there's a new balloon from Cook, the Advanced Micro 14 balloon, that are very low profile and can be introduced directly via these retrograde approaches. And you can use a sheath for your pedal access. There's a micropuncture. It's basically a micropuncture system. That's a 3 French system, and you can pass these low profile balloons through these micropuncture type sheaths. If we're up in the upper leg for the anterior tibial artery, you can actually put a 4 French sheath into those proximal tibial artery targets. This is that pedal access set from Cook. It's actually a micropuncture set, but with a shorter catheter. It has a check flow valve that can be put on the back for contrast injections and for hemostasis. And it comes with the usual micropuncture needle, but it's a shorter needle, so it's a little bit easier to use when you're trying to access a vessel in the foot. I like to actually use that micropuncture sheath now when I'm doing distal tibial and pedal access. I think it protects the access site from trauma, which may lessen spasm in some of those vessels. It does facilitate the exchange of different devices like support catheters and balloons, and it is compatible with passage of those low-profile coronary and now the Micro 14 balloon from Cook. This is that Micro 14 balloon. It does come in long balloon lengths. It goes through that micropuncture sheath. It's an over-the-wire system as opposed to the rapid exchange systems that most of the coronary balloons use, and it is hydrophilically coated to assist with passage. Here's another example. This is a patient who had an ulcer on the posterior, on the heel, with osteomyelitis of the calcaneus. Here you can see he's diabetic. He's got occlusion of the tibial peroneal trunk, disease in the popliteal artery. But he has a very nice posterior tibial target that appears to be providing blood supply to the area that needs to be revascularized. Here we've accessed that distal posterior tibial artery. Again, this is the inner sheath from the micropuncture set showing that we're in that posterior tibial artery target. Here you can see that we've put the Cook micropuncture pedal sheath in place into that vessel, and then we're advancing over an 014 wire, a quick cross support catheter. In this case, we were not able to pass in the true lumen, so here we've got a wire loop. This was a subintimal passage. The problem is that when we got up to the popliteal artery and the tibial peroneal trunk, we could not regain true lumen access, and we're still in a subintimal plane, and how to get re-entry when you're coming from this distal pedal or tibial approach. In this case, we used a modification of the double balloon technique, where instead of 2 balloons, we use a balloon that was introduced from below. This is a Maverick coronary balloon that was introduced through the posterior tibial axis, and then from above in the true lumen, we've introduced this outback catheter here. There's the Maverick balloon and the outback catheter. We can then deploy the needle, and we actually puncture the balloon and pass a wire into that balloon. And then once the wire is inside that balloon, we can advance the wire as we retract the balloon and then gain through and through wire access with that method. There's this technique. The other technique that's a little bit more commonly used is a so-called double balloon technique. Andre Schmidt has published on this, where you inflate 2 balloons, one in the subintimal space, one in the true lumen space, in an attempt to break that kind of intimal flap in between the two, and then to connect your access points. Once we've gotten across the lesion and we're about to perform our therapy, we usually give up our retrograde puncture access. Oftentimes when we've got the balloon inflated, we'll give up that access. This is a pneumatic cuff that we then put over the site where we've punctured to apply pressure, usually inflated at just enough pressure, around 50 millimeters of mercury, to gain access. Then you can complete your work while this cuff is up for about 5 to 10 minutes, and usually you have good hemostasis at the end of that, and there's no need to reverse the anticoagulation. This is that particular case. We had a cuff up on the distal leg. You can see that after we've completed the procedure, the patient's still anticoagulated. We have good inline revascularization into the posterior tibial artery. This patient actually went on to heal his wound and his osteomyelitis with debridement and wound care. And you can see there's no extravasation or spasm at the access point. There's not much in the literature describing outcomes, certainly nothing prospective in terms of prospective study looking at retrograde access techniques. These are some of the earlier descriptions of the technique, initially referred to as the Safari technique in this publication in 2005. The Leipzig group with Dirk Scheinert and Andres Schmidt have presented and started writing about this. And Marco Manzi even has shown some extreme approaches with direct access into actually digital vessels and into pedal arch vessels deep within the foot to gain retrograde access. To conclude, certainly these retrograde pedal and tibial access techniques appear to be important, and they may increase the success rates of our endovascular treatment for critical limb ischemia. Proper case selection, experience, and technique are really essential for optimal results, but after getting some experience doing this, you can achieve excellent results with this. Low-profile devices are currently being developed specifically for these retrograde pedal access approaches, and this may ultimately enable treatment of selected patients only using this retrograde approach. Thank you very much.
Dr. Luiz Carlos, fizesse seus comentários, por favor.
Parabéns, Dr. Darren, um excelente trabalho. Só duas questões. Eu acho que o principal talvez seja desenvolver estruturas um pouco menos calibrosas, de perfil mais baixo, para poder trabalhar retrógradamente. E a segunda coisa, o acesso que o senhor faz é por dissecção ou o senhor procura fazer punção nesses acessos distais? Qual a via para acessar o vaso e fazer a continuidade do teu trabalho?
I think that those are excellent questions, and I think to address your first question in terms of the development of lower profile devices, that's certainly in the works now. I know that there are some coronary devices that are already available that you can use, specifically balloons, but it would be really interesting if we can get some additional devices like stents and other treatment modalities that could even be introduced via these retrograde approaches. Also development of different re-entry techniques to use in combination with the retrograde approaches and re-entry devices may be important as well. But that's certainly in the works, and I showed you some of those products that Cook is actually developing specifically for these retrograde approaches. The other question as to whether or not we do this percutaneous or via cut down. In all these cases, these were done percutaneously. And so using either angiographic or ultrasound guidance, and I usually have found that the angiographic guidance is actually the easiest and quickest. There are a few cases that I've done via cut down, and actually you can do that in combination with certain surgical debridement and amputation procedures. So for instance, I've done retrograde approaches when doing a transmetatarsal amputation, actually directly accessing the vessel through that amputation wound as we're doing the procedure, but that's unusual. Usually it's a percutaneous approach for me.